And now he's working at St. Paul's in anesthesia, doing a locum, and he's going to go back and do further training. He signed up for another year of insanity. He's going to go to Toronto next year and do cardiac anesthesia. So great hot topic here, pulmonary embolism. Really looking forward to the discussion. And Duncan, why don't you take it away?
All right. Thanks, Dr. Serenas. And it's a pleasure to speak in front of you guys. Thanks for the invitation. So I wanted to talk about pulmonary embolism, specifically some of the risk stratification and management of the higher risk variety. The objectives here, I want to go through just some of the pathophysiology, which I think gives us the basis for why we feel maybe there's a group of people that would benefit from intervention above anticoagulation. Look at some of the evidence behind risk stratification, and then look at the evidence behind some of the novel reperfusion therapies that are out there. And then I want to wrap up by just introducing the idea of PE response teams as sort of a mechanism for dealing with this complicated disease process, and then hopefully have some time for discussion. So PE exists on a spectrum, and I think on the low risk end, about 20% of patients are in this category. It's not associated with a high degree of mortality, and we have a clear idea of what to do. Similarly, there's a very high risk PE that can be very scary. This is associated with significant mortality in the 15 to 30% range. And these patients, we can easily identify them. And for the most part, we know what the right thing to do is for them as well. But the majority of patients present in this sort of middle ground, intermediate risk zone. That's over 60% of the patients. And they still experience a mortality that's significant, anywhere between 3 and 10%. And so I think it leaves us wondering if there's something we could do over and above what we do standard systemic anticoagulation that might reduce that number. So PE is dangerous because it causes an acute RV failure. And I wanted to just go over this physiology to sort of illustrate the cliff that some of these patients are on the precipice of. A PE causes an increase in RV afterload, and that's from mechanical obstruction of the clot and hypoxic pulmonary vasoconstriction because of hypoxia, as well as some of the vasoconstrictive mediators that are released. Increase in pulmonary vascular resistance causes the RV pressure to increase, and the RV is not used to a high afterload, so it dilates. And when the RV dilates, the wall stress increases and myocardial oxygen demand increases, and there becomes an offset between oxygen supply and demand. Further, as the pressure increases, the RV, which is usually perfused in systole and diastole, becomes more like the left ventricle, and it's perfused mostly in diastole. That exacerbates ischemia. As well, you get a phenomenon of septal shift into the left ventricle. That compromises preload. It decreases cardiac output, and it means that the systemic pressure drops, which further decreases RV perfusion. So this is a vicious cycle, self-perpetuating. And just to add to this, there's a double hit phenomenon because CVP rises, systemic pressure falls, so the perfusion pressure for your organs reduces dramatically and you get organ failure. So let's start out just with a case. This is a 30-year-old female who presents with a syncopal episode. She's got progressive dyspnea for 2 days, history of a high BMI, and she's a smoker. On exam, she looks unwell, she's diaphoretic, she looks poorly perfused, and she's got hypotension, tachycardia, hypoxemia, tachypnea. Her biomarkers are up. She's got a lactate that's elevated, RV strain pattern on ECG. You can see on her CTPE, you've got a saddle embolus. The RV to LV ratio is elevated. You've got reflux of contrast into hepatic veins. And then on echo, we see a McConnell sign, a dilated RV, and there's tricuspid regurg and pressure overload. So this patient isn't difficult to risk stratify. This is a very high risk patient. I've got up here the European guidelines for picking up those patients, and those are patients who have a cardiac arrest, who have cardiogenic shock, which is hypotension associated with organ perfusion compromise, and then persistent hypotension, systolic pressure less than 90, or a drop of over 40. And these patients, even though there's a variety of guidelines out there, we have a pretty good consensus about what to do to manage them. They should receive systemic thrombolysis, and that's a class 1 recommendation. And I think sometimes it's funny when you go back and look at the evidence basis for some of these well accepted phenomena in medicine, the quality of evidence and support is actually not great. It's level B, which means single RCT or large non-randomized trial. And here's the RCT done in 1995. They set out to randomize 40 patients to either streptokinase or heparin. The first 8 patients in cardiogenic shock who presented, the 4 who got heparin died, the 4 who got streptokinase survived, and they ended that trial early. So I think there's going to be no high quality data produced to answer this question, but for now we can think of thrombolytic in this situation like a parachute. We're going to accept that it works, and until something might have a comparable efficacy, there'll be no head-to-head trial. So when you're looking at that intermediate risk, now it's sort of the clinician's job to find things that might elevate their risk and pick out a patient who's at a higher chance of mortality to potentially intervene and reduce that mortality. So we start with our history and physical. Things like syncope, pre-syncope indicate a low hemodynamic reserve. Symptom duration, more rapidly progressive symptoms are more concerning. Less time for the right ventricle to adapt. Similarly, we all know vital signs that are concerning, but a shock index less than 1, narrow pulse pressure, tachypnea, tachycardia, bradycardia, all of these things are associated with worse outcomes in pulmonary embolism. And then you're looking on exam for signs of hypoperfusion, capillary refill, modeling, things like that, as well as signs of RV failure. Moving on to the CT, most of these patients are going to have a CT angiogram that diagnoses their pulmonary embolism. And you can actually get a lot of information about the right ventricle from the CT-PE. Patients who've got a ratio of their RV to LV diameter in the transverse view that's greater than 1 are at a 2.5-fold higher incidence of all-cause mortality, and they're at a 5-fold increase of PE-related mortality. There's other things that you can see on CT that give you an idea about ventricular function. You can see contrast that is refluxing into the hepatic veins, and you can see septum that bows into the LV or is flattened. Interestingly, central thrombus load or clot burden on its own is not associated with mortality necessarily. And when you look at CT as a predictor of echo measured RV dysfunction, we find that CT it's sensitive, but it's not specific for RV dysfunction. So patients who have an RV to LV ratio that's close to 1, that can be overcalled by CT. Next, as you're waiting for your labs, you can use a clinical risk score. And the most extensively studied and most validated is the Pulmonary Embolism Severity Index. These are leaned on heavily in the European guidelines. And essentially what you're trying to get an idea is how will this PE interact with the patient's physiology? There's a long form version, which is a little bit complicated, and then a simplified version. And the simplified version has been prospectively validated. So that's a 6-point scale. You've got age, cancer, cardiorespiratory illness, tachycardia, hypotension, or hypoxemia. And if any one of those are present in a meta-analysis over 40,000 patients, you have an increased risk of 30-day mortality of 10%. And if none of those are present, your risk is low, it's less than 1%. So I think this is a useful tool. The thing that may not be perfect about it is if you're looking for a patient who would be someone who'd benefit from an intervention, 30-day mortality might not be what you're interested in. This definitely picks up a patient who's high risk, but you could imagine a 90-year-old with a small PE who's got a cancer diagnosis is risk stratified high. Whereas if you take a 30-year-old with a large clot burden, profound RV dysfunction, who's got a tachycardia that's only 105, they're going to risk stratify low. So it's not perfect, but it does work well. Troponin, as in many other contexts, predicts mortality in PE. So an elevated troponin in meta-analysis is associated with a 5 times risk of 30-day mortality. And when they looked at that in a prospective validation trial, you can see that combining it with the SPECI improves your risk stratification compared to one of those by themselves. So Troponin is a marker of elevated risk, but it's got a low positive predictive value, only 8%. So this may be a better test for excluding patients who are not high risk, but it doesn't necessarily find a small category of patients who could benefit from an intervention. Lactate in PE, just like in many other disease processes, predicts mortality. There's a 270-person study which was prospective, and it looked at patients who had PE and found if the lactate was greater than 2, they had a 17% chance of mortality, and that mortality increased as lactate increases. A follow-up study by those same investigators looked at 500 patients, and they found, again, lactate predicted mortality as an independent predictor, but on its own, it has a poor positive predictive value, only 10%. When you combine it with RV dysfunction on echo or with troponin, you can start to improve that positive predictive value up to around 18%. But the theme here is that no one of these risk stratification methods is going to by itself select for you a very, very high risk patient. And you have to combine them. Echocardiography, I think a lot of folks are getting more comfortable with point of care echo. And I think that formal echocardiography in PE is an important method of assessing RV size and function. There's a variety of different signs that you can look for on echo, the RV to LV ratio in an apical 4 chamber. You can look in the short axis at signs of pressure overload. You'll see a septum that looks like a D. You'd expect to see IVC that's plethoric in the setting of RV failure. And then some fancier things looking at the pulmonary valve acceleration time, tricuspid regurg jet velocity. You can calculate a 60-60 sign. And then other information that you won't get from something else is a clot in transit and a PFO. Of all these, the most consistent predictors of PE-related death are RV ratio greater than 1 and a TAPSE that's less than 16. And that's a measurement of annular plane excursion of the tricuspid valve in systole. And here's a bedside echo from a patient during fellowship where we picked up a clot in transit in the right atrium there. So how do these risk stratification tools get integrated into the guidelines? I think what's created some confusion is that there's a variety of terminology out there addressing PE risk stratification. So the AHA guidelines, they divide it into 3 risk categories: massive, submassive, and low risk. And in that massive or intermediate category, you could have potentially RV dysfunction or a biomarker that's positive or both. And so this is probably a very large spectrum of risk that exists within that risk tranche. And when you look at the European guidelines, they add another category to try and select a higher risk patient. So you need to have a PESI score that's elevated, RV that's dilated, and biomarkers that are positive. But reflecting on positive predictive value, the performance of some of those indicators, I think you can see why potentially even this intermediate high risk category wouldn't be a high risk enough group to benefit from an intervention. So let's consider another case. This was a case during my fellowship here at St. Paul's. There's a 70-year-old male who's got progressive dyspnea over 10 days. He's got a history of type 2 diabetes, elevated BMI, hypertension, and obstructive sleep apnea. He's got no history of syncope or pre-syncope, and he's had right leg swelling for about 2 weeks after he had an ankle sprain, and then shortness of breath that progressed over 10 days. On exam, he looks well perfused. He's in no distress. He's got a BP of 110/80, heart rate mildly tachycardic. He needs a little bit of oxygen to maintain his SAT over 90, and he's tachypnic with a respiratory rate of 28. His CT shows a large pulmonary embolism that extends into the right and left PA. He's got an RV ratio that's elevated and septal flattening, elevated biomarkers, and lactate. So I think this is the more common type of patient that we see, and it's the one that really presents a dilemma of multiple high-risk features, some possibly confounding features. He's got sleep apnea, he's got an elevated BMI, could he have some chronic RV dysfunction? But this is definitely an intermediate high-risk patient. And so what should we do with him? Should we use anticoagulation by itself? Would he warrant full dose thrombolytic, half dose thrombolytic, some of these new catheter-directed therapies, or a suction thrombectomy? Other things that are available are a surgical thrombectomy via ECMO so that he can't have a cardiac arrest. So why give thrombolytics? We want to prevent short-term death from RV failure or prevent a hemodynamic decompensation. Other reasons may be to prevent long-term complications. So chronic thromboembolic pulmonary hypertension or post-PE syndrome. So what's the evidence? I think many will know the PITHO trial, which is the largest randomized control trial looking at high-risk submassive PEs. And here they showed that giving thrombolytics could reduce hemodynamic decompensation, but that happened at the cost of increased major bleeding and increased intracranial hemorrhage. Looking at the long-term follow-up of that trial, they had 700 of the 1,000 patients followed up to 3 years, and there was absolutely no impact on long-term mortality. 350 of them were present for clinical assessment, and they found no difference in persistent symptoms, heart failure, RV pressure, RV function on echo, and definitive diagnosis of CTEPH. So I think this represents probably the best the best evidence to date of whether or not acute thrombolysis may prevent long-term complications. And on the basis of the evidence now, that wouldn't be a reason to give thrombolytics. There's a couple other trials, just for time's sake. I didn't want to go through them in detail, but the MAP-IT-3 showed less treatment escalation, no increase in bleeding using alteplase. Topcoat showed a potential improvement in a functional outcome at 90 days using thrombolytics. PITHO, we went over. The MOPIT trial got a lot of press as a kind of a cool name. They used half-dose alteplase, and they found that it decreased your PA pressure at 2 years, sort of uncertain clinical significance. And then I think the best long-term follow-up trial is the PITHO one that we just went over. And from these trials, I think it looks like there's some potential that there's a patient group who could benefit from thrombolysis, but we haven't identified that population in a refined enough way. And based on the variability in bleeding across these trials, it appears that there is some way that you may better understand and manage the risk of bleeding associated with thrombolytics. So how can we mitigate the risk of bleeding with thrombolytics? The MOPIT trial used a half dose, and I think there's evidence that that could be just as effective. And in addition, we borrowed this dosing from the stroke and MI literature with, I think, important physiologic differences in the disease process. If you imagine the amount of thrombolytic you'd need to dissolve a small clot in the brain or in the heart, you need a higher concentration than injecting into a vein in the arm, into the only organ that receives the full cardiac output of the body, probably a large surface area clot. And I think, importantly, you don't need full clot dissolution. It may just be a little bit of clot that you need to dissolve in order to pull that patient back from the cliff's edge of the RV death spiral. There's some evidence that perhaps alteplase is safer than tenecteplase, and I'll show you that. And could there be a way of coordinating our systemic anticoagulation with our TPA that's lower risk for bleeding? So this is a trial, multi-center RCT in China that looked at 100 milligrams versus 50 milligrams of TPA in a submassive and massive PE population. And you can see that all of the indicators of RV function, RV to LV ratio, PA pressures, RV wall motion, clot burden on CT had the exact same effect regardless of the 100 or 50 milligram dose. And when you look at the major bleeding associated, there's definitely a trend towards less bleeding in the lower dose group. And that was a significant trend when you looked at a low body weight subset of individuals. So I think there's evidence here that probably we're overdosing TPA when we give it in 100 milligrams. Certainly we are in patients who are less than 65 kilograms. If we look at the randomized controlled data in pulmonary embolism and break it up into alteplase and tenecteplase, you can see that in the alteplase trials, they have an ICH rate of 0.4% and a major bleed rate of 3.6%. And then look at tenecteplase, and you see a ICH rate of 2.1% with a major bleed of 11%. So it does seem like tenecteplase carries with it a larger bleeding risk. This is one of the more well-cited meta-analyses looking at thrombolytics. This is by Chatterjee and Jam in 2014. And what they showed is there is a mortality benefit, number needed to treat of 60, giving thrombolytics to PE. As we know, comes at the risk of increased major bleeding, number needed to harm of 18. And when they looked at that specific intermediate risk group, you see roughly the same numbers. I think what was interesting about this trial is in a group that was older than 65, you saw a really high associated bleeding rate. And in a group that was less than 65, there was really no significant association with major hemorrhage. So perhaps if we choose our patients carefully, we can reduce that bleeding risk by quite a bit. I think the systemic thrombolysis for intermediate high-risk patients still does not have clear evidence. There's a variety of reasons for this, but heterogeneous patient populations is a big one. One of the big issues is that risk stratification and severity has changed over time. Each study uses its own criteria. In addition, it seems that in the trial setting, they've got a low event rate compared to observational data. The Pytho trial, you saw mortality less than 2%, despite trying to select for a very high risk population. So maybe something about being in a trial makes it safer. I think another big cause of heterogeneity is that trials coordinated their tenecteplase or alteplase and heparin in a very different way. Some of them gave together, some of them apart. But on the basis of this literature, I don't think we can routinely give systemic thrombolytics to patients who've got an intermediate high-risk PE. But again, I think there are some patients who may benefit, and we need to, I think, try and identify those patients and perhaps be very systematic about how we give TPA in order to minimize the bleeding risk. So out of this comes the idea for catheter-directed thrombolysis. These catheters are inserted directly into the pulmonary arteries. They infuse TPA, usually at a low dose, 0.5 to 1 milligram an hour, over either 12 to 24 hours. Some of these catheters have fancy ultrasound energy that's been added to them to try and break up the fibrin. Probably the highest quality study evaluating this is called the Ultima trial. This is a very small randomized controlled trial, and it looked at one of the ultrasound catheters versus heparin, about 30 patients in each group. And they looked at a primary efficacy outcome of RV to LV ratio at 24 hours. And they found that in the catheter-directed group, RV to LV ratio went down 1.26 to 0.9, not in the heparin group. There was some minor bleeding, but no major bleeding. Now, most of the remaining trials looking at this are single-arm trials, so no comparator group. This is the Seattle 2 trial, which looked at 150 massive or submassive PEs. And again, they see a similar trend. You've got a reduction in the RV to LV ratio, you've got a reduction in the mean PA pressure, and a reduction in the CT obstruction index. All of that comes, though, with a significant associated major bleed risk of 10% in this trial. This is a randomized controlled trial called the Optelyce trial. They had no standard or anticoagulation arm, but this just compared different doses of TPA. So on the low end, 4 milligrams per lung, and on the high end, 12 milligrams per lung. And what they found is that regardless of the dose, you seem to get pretty much the same decrease in the RV to LV ratio. That's 25%. And there's a trend towards more major bleeding as you increase the dose. So I think provides some rationale for the idea that low dose TPA may still work. And then a final prospective registry is the PERFECT trial. And this looked at an outcome that they called clinical success in massive and submassive PE. And that was a composite of stabilization of hemodynamics, improved PA pressure, and survival to discharge. And they had 97% of submassive, 85% of massive patients achieve that outcome. Again, we've got no comparator group. And when you look at all of those trials together, they achieve essentially a very similar reduction in the mean PA pressure. So in summary, that's sort of the evidence behind catheter-directed therapies. I don't see any evidence here that giving TPA through a catheter right into the lung is any different than giving it in a peripheral IV. It's going to go directly to the lungs anyways. The quality of evidence here is pretty poor. When you take an evidence-based approach to evaluating these trials, they don't tick a single box. They're industry designed and funded. They've got no comparator arm, and they're looking at surrogate outcomes. So I think there's a lot of problems with the literature supporting this, and they still have significant bleeding. So maybe percutaneous thrombectomy can be the answer here. Is this the PCI of pulmonary embolism we've seen in stroke and MI? We've moved away from sort of barbaric methods of getting rid of clot and towards more elegant things like clot retrieval through embolectomy systems. And there's two devices that are relevant right now, the Inari FlowTriever and the Penumbra Indigo embolectomy system. And both of these are in the process of being made available at St. Paul's. I think the Penumbra system is available, and the FlowTriever, they're just getting trained on it. Major benefits in this would be that you could potentially avoid thrombolytic altogether, really mitigate your bleeding risk. You also could have an immediate effect. If you suck out a large clot from the pulmonary artery, potentially right in the 30 minutes it takes to do that procedure, you've pulled that patient away from a position of really tenuous hemodynamics. It also is performed in an IR suite. So this is an ECMO capable location. If things go really sideways, you have the option to put the patient on VA ECMO. And this could have an application in even the high-risk patients, especially if they've got a contraindication to TPA or if they've failed TPA. This is a technical procedure, so it means that evidence doesn't necessarily generalize, although from what I've read, it sounds that an experienced IR practitioner is proficient in this after about 3 to 4 cases. And when we look at these studies that I'll show you, they're multi-center studies, and most of them, the centers were doing about 5 cases. So it's not as though it all happened at one center that was particularly expert. So the FLAIR study, this was a single arm study that looked at the Inari FlowTriever device. And the FlowTriever, I've got a picture on the top right there. It's a 20 French catheter that goes into the pulmonary artery over a wire. There's an additional catheter that people make variable use of, but it has some discus that can be deployed into a clot and help you to retrieve it into the aspiration catheter. So the FLAIR study is a single arm trial, 100 patients, and they looked at a primary efficacy outcome of RV to LV ratio, and they found that it had an effect from 1.56 to 1.15. The procedure time here in this trial was about 90 minutes, and they had a 4% major adverse event rate. So 1 major bleed, 1 pulmonary vascular injury, 1 patient who needed to be intubated in the procedure, and 1 who had VF because they also had a STEMI at the same time. This is a similar study, but this is looking at the Indigo aspiration system by Penumbra. I think main difference here is this is a much smaller catheter. It's 8 French. It has a proprietary algorithm that helps you to decide whether or not the aspiration catheter is up against clot or just in a vessel with blood. So you minimize the aspiration of blood and blood loss associated with the procedure. This was 120 patients with intermediate risk PE and single arm trial. Again, they looked at the same efficacy endpoint. They saw a 27% decrease in the RV to LV ratio, and they saw a relatively low 1.7% major adverse event. And that was 3 events experienced by 2 patients. One of them was a PE, a rupture that ended up also having an access site hemorrhage. And then the other was just an access site hemorrhage that required transfusion. Biggest registry here is the FLASH registry. And last fall, the US published their cohort. So that's 800 patients, mostly intermediate, some high-risk patients. And what they demonstrated is that on the table, you can see hemodynamic improvement. They dropped the mean pulmonary pressure by almost 8 millimeters of mercury. In patients who presented with a low cardiac index, they were able to improve the cardiac index by about 20%. So supports that idea of an immediate hemodynamic benefit. I think impressive that they had a 1.8% major adverse event rate, and their 48-hour mortality of 0.3%, zero device-related adverse events. So this looks kind of promising. Again, we've got no comparator arm, but if you compare it to the historical context data, it looks promising. And then most recently, the FLAME study, this was published just in October of this year. And this was a prospective multi-center parallel group enrollment trial. So they looked at patients with high-risk PE, so PE with cardiogenic shock associated. And if they came in and the physician chose to use the Inari flow retriever device, they were in that group. And if not, they were in the context group. So by definition, you cannot compare these groups. They're not randomized. And just to give you an idea of how different they are, I've got some of the demographics. You can see that much more profound shock in the context group, more procedure after hours, as well as more of them, almost twice as many intubated. And I think there's some interesting racial disparity in how this catheter was used. But when we look at the results, you see primary endpoint, which is a combination of all of the things you see below. So in-hospital mortality, bailout to an alternative strategy, and then deterioration, major bleed. The in-hospital mortality from the suction thrombectomy group was impressively low, 2%, especially when you interpret that in the context of high-risk literature. In the context group, 30%, which is probably on the higher end, but it's definitely within the range of what you could see. When we look at how the patients in the context arm were actually treated, 69% of them got systemic thrombolytic. There were almost 25% who got just standard anticoagulation or systemic anticoagulation. And then a small proportion got catheter-directed therapies or surgical embolectomy. So I think taken all together, these advanced reperfusion techniques have it's a disappointing level of evidence. And it's definitely evidence that the industry influence is alive and well in medicine. There's been thousands of patients exposed to these devices, and no high quality evidence has been produced at all. I don't see any compelling reason to use a catheter-directed thrombolytic over a peripheral IV low dose if we're going to go with a thrombolytic. I do think that the preliminary data for percutaneous thrombectomy is pretty encouraging. Obviously, we'll need more robust data, but I think it's promising, and I would suspect that that's the future. I think trials to look out for. The high PITHO trial is going to look at catheter-directed versus systemic anticoagulation. There's a number of other randomized trials that are going to look at this this question. And in that trial, they've selected a higher risk group, so intermediate high risk plus some hemodynamic derangement, so shock index, tachycardia, hypoxemia. So they're trying to refine the risk categorization. And then the STORM PE is going to be a randomized trial looking at the penumbra system versus standard anticoagulation. And I was able to find one registered trial that was going to look at peripheral low-dose TPA versus catheter-directed. Obviously, the catheter companies don't have any incentive to make that trial happen, but I hope it comes to fruition. Open embolectomy, I just wanted to talk about this because it does have some application, maybe less as percutaneous embolectomy becomes more available, but traditionally the indications here were absolute contraindication to thrombolytic in a high-risk PE. I think you have to remember that these patients are having cardiopulmonary bypass. They're going to get 50,000 units of heparin. There's significant anticoagulation. So if your bleeding risk was high to begin with, this doesn't have a low bleeding risk. Also, possibly there's a unique indication here in a patient who's got a clot in transit that's sitting across an open PFO, very high risk to embolize and stroke. And then the last indication would be potentially someone who you think might die before thrombolysis has an effect. I think historically, surgical embolectomy was thought to be extremely high risk, but there is some data, and I think it's enjoying a bit of a renaissance now, that its mortality is probably comparable to thrombolytics in general. This is a 13-year experience from New York State. It's retrospective, but they looked at all patients who received either thrombolytics or open embolectomy. Similar mortality. Most of the people who die here died on anesthetic induction, which is not surprising. There's a lot of physiology that's hard to manage when you go from negative to positive pressure with an RV that's failing. So that sort of brought up the idea of should these patients, if they're going for surgery, be put on VA ECMO first? And VA ECMO is an interesting idea in PE. It's, if you think about it, one of the perfect indications in that it's a very reversible process, and it's treated by ECMO well because you bypass the whole heart, you maintain perfusion to the vital organs, and you give yourself an opportunity to think of a strategy to deal with the PE. So ECMO can provide a bridge, whether that's anticoagulation, letting the PE dissolve on its own, using fibrinolytic, or a catheter or suction-based strategy. It has some theoretical appeal. There's no good evidence for this. There's a 52 case series published that showed that ECMO in PE had a mortality at 30 days of about 61%. This is similar to ECMO mortality in other areas. Usually things aren't going well when you're calling for it. This is an indication for a code ECMO here at St. Paul's. So it's something to keep in mind. So back to the case, we had a 70-year-old man, acute intermittent high risk PE. And what did we do? I think we followed what most guidelines would suggest that you do, gave him an enoxaparin therapeutic anticoagulation. We admitted him, I think an HAU would be perfect, but we don't have one here. So admitted to the ICU for monitoring, ordered an echo. Unfortunately, 3 hours after we assessed him, he had a cardiac arrest. We gave thrombolytic 100 milligrams and ran along resuscitation, but weren't able to resuscitate him ultimately. And I think this is the type of case that makes you wonder, should I have done something different for this person? And this is exactly what I think we're hoping to find, is an intervention to offer a patient who's at substantially high risk of hemodynamic collapse so that we can have a better outcome. And at the time, suction thrombectomy, not an option, talked about it with colleagues and mentors in the ICU, and honestly don't know that I would do something different if I had a do-over. But it certainly makes you hope that we're able to potentially refine risk stratification and apply some new technologies that might save patients like this. So just quickly want to introduce the idea of a PE team. And these have come up because PE is common, it's potentially life-threatening. We don't have universally accepted risk stratification, and some of these patients need to be managed relatively urgently. Additionally, these are diagnosed all over the hospital. Every specialty is ordering CTPE studies. Not every specialty is going to be finger on the pulse of new literature. So this is to help sort of organize the logistics of accessing some of this care and doing a proper risk assessment for patients who are on a high risk spectrum of PE. This was introduced by MassGen in 2013 and essentially combines the operational concept of a heart team, which is a multidisciplinary team that looks into complex cardiac patients and how to manage them with surgery, interventional cardiology, and medicine. And then the concept of a rapid response team, which I think has been widely applied, but it's the idea that you can intervene on a patient who's deteriorating and try and prevent a code or a cardiac arrest. So what's happened locally? After MGH came out with a PE team, it rapidly expanded across the United States, into Europe. VGH was the first hospital in Canada to have one, and they made that in 2016. Manitoba, where I'm from, just came out with a PE team in March. Fraser Health has just come out with a high-risk algorithm. They decided they don't have the resources to have a formal team, but they've published a pathway, and I'll show you that. And essentially, this is a murky enough subject that this is highly individualized by institutions. Many institutions have to decide how they want to manage this sort of gray area of a disease, and then just try and come up with a standardized approach. This is in the European guidelines as a recommendation that if you do have the resources, you should consider a multidisciplinary team to deal with this disease entity. And that's not based on any high quality evidence or a strong recommendation. Just to give you an idea, this is what the VGH PERT team looks like. It's diagnosed by a radiologist and activated through switchboard. You get a PERT physician as well as an RN and interventional radiology and the ordering MD, who are all paged. And then the PERT team does a risk assessment and they host a multidisciplinary call to try and consider if a patient is high enough risk that they would warrant consideration of some of these additional therapies. Just out of interest, this is the Fraser Health pathway. It essentially relies heavily on the European guideline, where you are risk stratified into an intermediate high risk on the basis of PESI, RV dysfunction, and a positive biomarker. And if you end up in that category, you get referred for a discussion with critical care, IR, and the MRP. Is there any evidence that this has an impact on outcomes? MGH published their 10-year experience. And what we know for sure is it improves or increases the utilization of advanced therapies. So they had an increase that was dramatic over the years before the PERT and after the PERT was introduced. Hard to decipher because these technologies became more accepted, more widely available over that same time period. When they looked at 30-day mortality, major bleeding, there's no difference in the pre-PERT and post-PERT era. Lots of challenges associated with this idea. You know, it's an urgent disease, hard to get a lot of people on the phone to make a quick decision. Typically, only one person is going to be able to actually assess the patient. So you're not really speaking from an even ground. How do you fund it? You can't all probably bill a consult on this one situation. So that becomes something that needs to be sorted out. And then, are you centralizing a disease that, you know, physicians used to be able to manage on their own, and taking that experience away from them, sort of de-skilling the general medical population? So where do we go from here? I think PE is a really challenging disease, and risk stratification as it exists now probably isn't refined enough to pick up patients who would necessarily benefit from something additional. I think there is probably a subset of hemodynamically stable patients who could benefit from thrombolysis, and there's probably a safe way to do that. And I think percutaneous mechanical thrombectomy is really promising, and it's an exciting new alternative. The era of this device-related therapy calls for robust randomized control trials with clinical endpoints so that we can properly assess how these should be integrated into our practice. And I think similarly, having a strategy for addressing a complex entity like this is helpful, but if we're spending a lot of resources, time, and money on things like PERT teams, we should apply a similar level of rigor to ensuring that those have an impact on outcomes as well. I'd like to thank everyone who helped me out in the creation of my presentation, and open the floor up to discussion. Dr. Wally?
Sorry, I'm not near a microphone, so I'll just yell.
Okay.
How about the ultra low dose? Like instead of 50, something like 25 that you might repeat at a time interval. Is there much evidence in any direction on that?
I think essentially it depends on whether you believe that the catheter in a PA changes anything about the systemic effect of TPA, but those regimens were about 24 milligrams when they gave it through a catheter over an extended period of time. So ultra low dose, I think we have some reasonable amount of evidence to suspect that it would work. And I think if it was me, I would probably start by using very low doses and with the aim to use the minimum dose required to get some sort of hemodynamic improvement. As for like quarter dose versus half dose TPA as a regimen, has not been studied in a randomized control fashion as a bolus or as a 1 hour infusion, but lots of evidence looking at lower dose, lots of case series looking at ultra low dose, you know, even in the 4 milligram bolus at a time, for just case reports. So I think that has some appeal in the way that you could apply it in especially the critical care environment, just giving small doses and titrating hopefully to effect. And the best evidence that low dose works is from the catheter-directed literature. Again, I'm not convinced that putting a catheter right into the clot is necessary in order to have that effect, but there's no evidence to show otherwise. Dr. Sarinas, yeah.
Great talk. Thank you for putting that together, synthesizing everything and just updating us all. Just a couple questions. I'll start with my first one.
Yeah.
You kept referring a lot to the RV LV ratio resolution. So echocardiographic parameter that was noted in some of the studies. Does that correlate with outcome in the end, or is it just a parameter that we're just noticing that doesn't necessarily translate to outcome improvement?
Yeah, I think that's where this evidence really falls short. Like, we're looking at surrogate outcomes. We're hoping that if the RV improves, that means hemodynamics have improved, and that means less death because we've pulled them back from that very precarious situation. There is evidence, in the form of echo and CT, that if that ratio is elevated, your likelihood of dying is high. So in the risk stratification literature, there is evidence that's associated with mortality, but there's no robust evidence that if you decrease the ratio, that will decrease mortality. It's inferred.
Okay. And then my second question, I'm not sure how easy this one is, and it's not meant to be hard. I'm looking for your insight. Which subset of patient that's hemodynamically stable that's high risk, would you put in a category that would warrant thrombolysis outside of the high risk features that we talked about, the dysrhythmias, the hypotension, the shock, etc.?
Yeah, I think that's what is really tough. And I don't think we have a robust algorithm that we can apply and say, all of these patients that meet this criteria deserve some sort of reperfusion therapy. And that's why it's such a tough question. And that's why you have things like PE teams or algorithms that facilitate a discussion individually, like individual basis, case by case. Does this patient have the physiologic risk and the markers of a high enough risk PE that it would warrant doing something extra? So from my perspective, I would rely probably more on hemodynamic variables than things that are associated with a 30-day mortality if I was going to try and pick something to increase the likelihood of an intervention preventing PE-related mortality. So shock index, tachycardia, borderline blood pressure, I think those would all be things that would worry me slightly more than troponin and BNP. And then putting the whole picture together, I think you can get a sense of what the overall risk is, but that's not a good answer to the question. But I think the issue is we don't have a refined risk stratification tool that we can apply and it works on everybody. We got to take an individual look at this until maybe the evidence develops and we're able to carve that out. And that's why these PE teams and algorithms have come up so that we can try and, on an individual case by case basis, pick out patients that we think, but it's clinician gestalt in addition to some things that are based on evidence. Dr. Kassem?
How do we capture the experience as we're moving towards your perfect team or whatever you are? How do we capture everybody's experience to try to create our own evidence?
Yeah, that's a good question. I guess keeping track of data would be an important first step. I think comparing outcomes over time is inherently difficult, and you can do temporal analyses and things to try and control for that. But that would take the mind of a great researcher like Dr. Wally to try and come up with a good plan. But I think you bring up a good point, and that was part of my point, is if you're going to apply something like a PERT team that has significant, cost and resources associated with it, you should also study to make sure that this has at least some positive impact. And so being methodological when you go about starting something up, I think would be an important thing. And it's very difficult because the literature is going to evolve and devices are going to evolve over time. So to know whether exactly, day October 30th, we had this PE team and now mortality is down, whether that was the cause, I think will be challenging, but I think we should try and have some sort of quality assurance and reporting.
And I just got to say one more thing.
I just have a comment, right? Thank you so much, Duncan. It's really helpful to hear the summary of it. I'm all for setting up some sort of a standard. So us can communicate with the institution. As much as we like to have some sort of assessment criteria, something objective, maybe an RV, ratio, or number, I still feel like that the key will be clinicians to just stop. You mentioned, right? You look at the other scoring system, we have the Wells criteria, so on and so forth. There's always this item where clinical just stops part of it. And oftentimes that's the most important. So back to what Dr. Cassius mentioned, unless we move forward with some sort of standardization, try to practice using it as an organization, we'll never gain that experience and hundreds of stuff. So I'm happy that we're taking the first step. Really happy to see it.
Thank you. Yeah.
I'll just add
Gotham, yeah.
Here as well, our staff and master's here. So we have been looking at getting all the presentations from various providers of all the devices, everything from Flurry to Angiojet, dynamics, et cetera. The problem is the cost of everything. So we, as of last month, we were all using Angiojet, which is a very historical aspiration device that uses TPA, and that's costed at about $1,000 per device for us. Now all these new devices are in the 7 to 10 plus range. So we have done some cases, and I will be talking about this at a future presentation as well to the group. We've done some PE cases that involve using Number. We have colleagues of ours at RCH and sort of liaison who are using it already and have good advice related success with it. But I think going forward, any case that comes out, at least our department, gets scrutinized very thoroughly. So I think whether it's a registry or whether it's some kind of research resource, but what I can assure you is every case that gets done in IR with all these new devices will be looked at, the data will be collected and maintained, because the funding is going to be an issue with us. We're going from using $1,000 device to now $10,000 device, and if these numbers are around, we have to justify it. We have to do funding as well. So the other night I ended up using a number case, and the number we decided to write just to write a little bit at was ridiculous, but it was required at the end of the day. I can't imagine what an RE is going to do. I think an RE is a 10 area. So we have acquired it. We've acquired an RE, we've acquired that number as well. But certainly we will need to give a close track of what the results look like to justify this to our
So just a comment that my concern is not, I think it's wonderful, the job was really good. My concern is that at individual M&M rounds, something's learned about this specific patient, but it's not shared usually with the whole group, because the whole group isn't together. And so it would be very helpful to try and look at
Yeah. Yeah, certainly. And I know at VGH, when they started their PERT team, they used a lot of catheter-directed TPA, and I attended their M&M rounds, that essentially they found that their bleeding rate was way higher than the literature. And so they abandoned that technique completely. But I think, self-assessment, reassessment of what we're doing, is it working here in the way that it works elsewhere? Super important. But yeah, I think, this topic is so challenging because it really leaves something to desire. You want to be able to do something extra for these patients. But we're really not supported by super high quality data. And so it leaves us in a tricky position. Yeah, one last question. Sorry.
Whoever's in the back. I guess on the follow-up on that, I think given the numbers, and it's so hard to get the event rates that's needed over the years, potentially one other step would be to actually form networks across the different IRs within Surrey, within RCH, with us, with PGH, and really break the silo of each hospital kind of doing their own thing. So if the numbers at RCH or at Surrey are showing that a $10,000 device is working and it's saving lives, it's going to reduce the workload that Dr. Sowell has to do to justify the use of it. So I think perhaps one other step would be to even create those networks across the different hospitals at that level, and really understand their data, understand their numbers, and really seek strength in education.
Yeah, certainly. I think there is a thing called the PERT consortium, which these groups share their experience and try and come up with, as a group and with a collective experience, recommendations on what to do. So yeah, extremely good point. I think that is definitely, when you're sort of navigating an issue without clear evidence, one of the ways to do it is to make sure that you're sharing the experience. Okay, I think that's time, so I'll wrap up, and thanks so much for your participation.
Very nice.
Thanks, Dr. Wall.
I learned lots of good stuff.
Well, that's perfect. Thanks for coming. I'll see you on your
Just actually shows very little, maybe a little bit of. He was on like 3. I was like the one steroid, and then a small improvement and everything else. Exactly. And you know, because my clinical question was, I think this is a viral acute bronchitis. And it was. It is. But I'm just thinking ahead, like if you deteriorate and you yeah. I know they would. I read about it in the they call me. And they might do it in the but I've never heard of it. It was mostly around like someone's a bad heart. Is he immunocompromised? You know what I mean? He may not be like classic immunocompromised, but he's compromised in an area. Yeah, exactly. Yeah, because it was in They also talked about using one of the meds. I know.